health education program brought to you by Hudson Valley Hospital Center. Each month we bring you a new topic and a new guest. And this month I'm very excited to have on two special guests. We have Dr. David Vint and we have Dr. Scott Russinoff, and I'm going to tell you a little bit about each of our doctors here today. Dr. Vint is an anesthesiologist at Hudson Valley Hospital Center. He received his medical degree from St. George University School of Medicine and completed his residency in anesthesiology at SUNY Upstate Medical University. He's been in practice for 8 years and he's currently licensed to practice in New York and New Jersey, and we're very happy to have you here this evening. And then we have Dr. Scott Russinoff. He's an orthopedic surgeon and a member of Mount Kisco Medical Group. He specializes in total joint replacement and he has offices in Jefferson Valley, Fishkill, in addition to Hudson Valley Hospital Center office right here. And he received his medical degree from SUNY Downstate Health Science Center at Brooklyn Medical School, where he also completed his residency in orthopedics. And he completed a fellowship at New York Medical College, and he's board certified in orthopedic surgery. That's quite a lot. Very impressive. So today we're here to talk about, basically we're talking about pain, and we're talking about controlling pain. And I think that, you know, one of the major things that prevents people from scheduling surgeries are you know, the fear of pain and how that's controlled. So Dr. Vint is an anesthesiologist. Maybe you can explain to us a little bit. We're going to talk about peripheral nerve blocks, which sounds a little bit intimidating, but maybe if we start at the beginning and talk a little bit about anesthesiology and managing pain and how we do that, maybe we can work our way to that topic. So maybe we can start out and you can give us a little background as to, you know, how we control pain in the OR and afterwards traditionally, and maybe talk a little bit about this new concept.
So pain is a very important topic, especially in the post-surgical patient. Nowadays, pain is considered the fifth vital sign. Pain is judged on pain scores. So, you know, how is your pain 1 out of 10? And we really want to try and minimize that. So traditionally, in the past, pain is treated with narcotics, so morphine or morphine-type drugs. Problems with this was that, you know, especially orthopedic surgery is very painful, and the more morphine you use, the more side effects you're going to have. These side effects being problems breathing, problems with nausea and vomiting, and really using one drug to control pain is really not as effective as using a few different types of ways to treat pain. So one of the things we started here at Hudson Valley Hospital is our regional anesthesia program. Now what that involves is using local, like when you go to the dentist you get Novocaine in your mouth and it's numb, using local anesthesia to numb the parts of the body that you're having pain or surgery on, and to try and cut down on the amount of narcotics that we use. So cutting down the amount of narcotics can cut down a lot of the nausea, the vomiting. And it's really a better form of pain control to kind of use these two things at once. Right. As opposed to just one.
Go back a little bit and say, you know, I'm scheduled to have a surgery or whatever, and how do you prepare the patient? Maybe Dr. Russinoff, you can talk a little bit to this, you know, when somebody comes in and they need to have a hip replacement or, you know, a knee replacement or whatever, and how do you prepare them for, you know, what's going to happen in terms of the anesthesia and the OR?
So most patients are obviously scared of having surgery for whatever reason it is. The nice thing with hip and knee replacements is that the patients are usually having pain before surgery. Right. So, you know, we're telling them it's going to be a different type of pain afterwards. Sometimes it's a more controllable pain, using some of our newer techniques also that we have available to us. And the reason why orthopedic surgery hurts, especially hip and knee replacements, is we do the surgery and then we want the patients to use their new joints. So we want them to walk on their new knee and their new hip. We want them to bend the new knee and the new hip. If we said just take it easy and don't use it, it wouldn't hurt that much. And then patients have heard stories from the past or from other patients that, you know, maybe the surgery it was more painful than they thought. They couldn't believe how much pain they were in. But a lot of that's from the past also. These days, the last several years, as surgeries become more or less invasive. It's made the recovery easier. The pain's a little less. And then in the perioperative period, we're using these peripheral nerve blocks. We're given certain medications like anti-inflammatory medication before surgery. That helps cut the pain down. So right from the office, I try to relax the patient, and tell them it's a good thing they're having surgery because we're going to take their pain away. They may temporarily have a different pain, but we can control those pains and get them moving and get them up and about.
Right.
And the goal is to get the patient moving after surgery. We don't want them to have pain after surgery. We want to be able to control their pain. So we try to calm down their fear of the pain, and patients do well. I mean, we're getting patients out of the hospital quicker these days. And patients are just moving. We're getting patients up same day just to get them up and get them moving and get their pain under control.
Right. Well, that's what I wanted to talk about. First, basically in the OR, you're using, with this kind of surgery, you're using local, you're using general. Like, what's the difference? I mean, for the person at home, obviously general is when you're out, and local is when you're awake, and the localized part of your body is.
Well, in terms of, usually for joint replacements, we use spinal anesthesia, like
Okay.
what women have for C-section.
Okay.
And that's considered a form of local. And since the whatever joint you're having replaced would be numb, you can actually keep the patient asleep with a light IV sedation, kind of like a colonoscopy.
Okay.
So, one of the fears that we deal with is patients say they don't want to be awake during surgery, and that's never the case. They're asleep. It's just a matter
So
of
even though they're not out through anesthesia, they're like in a sleep.
they're comfortable, they're
And
sedated, and yes,
There's no pain.
There's no pain, and usually there's no memory of any surgery, even with a local.
Right. So the problem isn't really during the surgery. It's really, we're talking about after the surgery, when somebody goes home and they start, because they're not really feeling pain as they're, going through the surgery. It's afterwards, and talking about ways to kind of help people to recover more quickly, and talking about, whether they need to be admitted, whether they can go home, and how that works. So maybe you want to just talk a little bit about that.
So usually for joint replacements, they get admitted for a few days, and what we try and do when their anesthesia from the actual surgery wears off, we try and minimize their pain. One of the ways we do this for our total knee replacements is to use what's called a peripheral nerve block. And basically we numb the nerve in the leg that causes pain in the joint. We do that with an injection of local anesthetic, and then we actually leave a catheter behind. This is just like a little piece of fishing line, a little piece of plastic. This is inserted probably just a few centimeters under the skin to surround the nerve, and then the local anesthetic comes right out of here. Now this basically will go into the leg, around the nerve, and this will be coming out of the body, and then we connect it to a pump, which we have here. And this pump actually gives a drip of local anesthetic through the catheter. And then when they do their rehab, they can carry the bag right around.
So it's battery operated, so it's portable and whatever?
There's it works on scientific physical principles that allow it to run without a battery.
Oh,
it's
I
kind
see.
of just
Okay.
like a mechanical
So it's kind of
pump.
like gravity or whatever that.
Right.
Works with
So that, and then they just carry that around. It's nothing for them to think about, nothing for them to do, other than don't leave it behind.
Right. So they would have this in the hospital as well as when they go home? So maybe you can just take us step by step. So they're in the hospital and...
So for the joint replacements, they're in the hospital. They're going to have this pump in place, and usually we'll take it out before they leave and go to their next destination, whether it be home or rehab. For other surgeries that we do, mostly orthopedic stuff, whether it be shoulder arthroscopy or an ACL repair, those patients, as long as their pain is controlled, can leave the same day. So what we do is insert the catheter, and we can send them home with this pump, and then kind of manage them from home and get their pain under control that way. That way, they're not in the hospital, they're at home, they're comfortable, they're in their own chair, in their own bed, and not having to kind of stay around.
Right. So, I mean, obviously, this is all aimed towards it's preferable for people to go home. You know, they want to have surgery, they want to get it done, but nobody really wants to stay in the hospital. And, you know, we don't want you to stay in the hospital because we have other patients coming in, and just the cost of health care, you know, continues to rise the longer people have to stay in the hospital, in a hospital bed. So, you know, tell me a little bit about, because we had talked earlier about this, about how, you know, this is just helping, you know, the whole picture in general in terms of cutting costs, in terms of making people comfortable by getting them out of here quicker, and how we can do that, you know, safely so people feel comfortable.
So patients, they feel like they need to stay in the hospital. They're almost scared to leave sometimes.
Right.
But once they go home, they're more comfortable. They're in their own bed, they have their own food, they can dose their own pain medication. They don't have to wait for a nurse to bring them pills if they're having pain. So usually by 3 days after surgery, sometimes 2 days after surgery, patients are typically ready to go home after a hip or a knee replacement. Shoulder surgery, usually go home same day. But the hips and knees, once you get walk-in and the pain's under control, usually by 2 days, your patients are fine with just pills for pain. Either combination anti-inflammatory medication and narcotic pills. And a lot of times when patients come back in 2 weeks, especially the hip replacements, they're walking maybe with a cane, maybe they're off a cane already, off pain medication. Knee replacement patients tend to be a little bit more painful, and they need pain medication a little longer. But the nice thing is, you know, we try to encourage patients to get moving and get home. There's no reason to lay around a hospital 3, 4, 5 days anymore. It's bad things can happen in a hospital. As much as we try to keep things safe, you know, it's a place for sick people in the hospital.
Correct.
Right. So patients are actually safer to be home once they physically can get themselves in out of bed and go to the bathroom on their own, which is usually, like I said, by 2 to 3 days after surgery.
Right. So this, correct me if I'm wrong, would replace the narcotics, or would be used in addition to the narcotics, or how would you?
So we would use this in addition to the narcotics.
Okay.
So these days, pain treatment is what's called multimodal, so many different things that we use. Excuse me. So instead of using one thing to the point of excess where it would cause side effects, like nausea, vomiting, like pain that would keep you in the hospital, we use a couple of different things in lesser doses so that it kind of can curtail the pain more effectively.
Right.
And that's how we do this. And in terms of discharging patients, you know, the things that will keep them here if they're supposed to go home the same day, if they're nauseous, vomiting, you know, their pain is uncontrolled, you know, that will significantly raise the cost to them and to the system. So that's kind of why we like using this form of local, because it helps to cut that down.
Right, so they don't have to take as many narcotics, and maybe they don't have as many side effects as you were talking about. And some people are very sensitive to those narcotics. I know I am. I have those symptoms of nausea and all that other stuff when I take those. So this would probably be preferable to me, as I wouldn't be feeling that as much.
Right.
So do people now, is there anything that you need to instruct people on with this, or this is just, you know, you basically putting it on, they have it, and you know,
So I put this in place. We put this in place before the surgery, and we instruct them kind of as they get here, while they're here. We speak to their families so that they understand kind of how this works, what side effects from this they might want to look for, you know, how exactly their experience should go, what they should feel like, when it should wear off. So we're constantly educating patients and their families when they come to the hospital and while they're here.
right.
So that, you know, they kind of get an idea of what to expect. And then they'll go home with written instructions, a set of sheets, and contact information. Whoever their anesthesiologist is for that day, they'll get their contact number, and should they have any questions or any issues, they can call from home and get instructions that way.
I see. So they don't need to be worried about, like, as for instance, if I were leaving, I'd be like, oh, you know, how much do I give myself? Am I going to, you know, am I going to give myself too much? And that's all.
Yeah, it's all
taken care
everything is done by the pump, and once the pump is in place, nobody really needs to worry about it. It does its own thing.
Right. And then you would come back before your regular visit, whatever your follow-up visit. And then that would be, you'd be off the pump, you'd continue to use it as long as your doctor thinks it's necessary, or? Usually
we instruct people 3 days after surgery. That's how long, that's how much medication is in the pump.
Okay.
We send them home with instructions. A lot of people are comfortable actually just removing it themselves. It's just basically like peeling off a Band-Aid, and you take the dressing off and the catheter comes right out, because it's very superficial in the skin.
Right.
Other people that are not comfortable doing that, sometimes they have a family member or neighbor who's in healthcare and they come over and do it. And then ultimately, if they don't want to do it, they can go to a physician's office and have it done when they get follow-up.
So how do you, Dr. Russinoff, how do you see the difference with this particular method as opposed to not having it with your patients in terms of hospital stay and how they like it? And
Right, so the main thing for us after hip and knee replacements, especially with the knee replacements, is we get patients moving quicker. So we're getting patients up the same day now, where used to they would spend at least overnight in bed before getting up. Now when they get up to the floor, the nurses are able, with the physical therapist, to get the patients walking that afternoon. If the surgery is later in the day, then the nurses will try to get the patient up in the evening, either sit them up on the side of the bed. And that's helping just to get them mobilizing and getting them moving quicker. Our length of stays gotten shorter, so average stay used to be 3 to 4 days. Now we're looking more 2 to 3 days after joint replacement surgery. So it's been helpful because patients are in less pain, they're moving quicker, they're going home quicker.
Right.
So it's been very beneficial since we've been doing this.
That's great. So one of the things that we had talked about earlier was that the whole idea of not just, people leaving the hospital earlier, but not having to return to the hospital and being readmitted because of pain or, other problems, and that there's fewer people who, come back, because sometimes when people have surgeries and they feel uncomfortable or whatever, they may end up coming back into the hospital.
Yeah, and a lot of them, they would come back for not even pain issues. They'd come back because of the side effects of the pain medication. So they'd come back with nausea or constipation, and we're not seeing that these days because they're not using as much narcotics early on, so we're not seeing the side effects of the narcotics like we used to.
So how long have we been using this at Hudson Valley Hospital Center, and what do we hope to, accomplish in the future? What do you see as the next step for this? Or
we've been using this since January. I think we've seen, like Dr. Russinoff was saying, excellent results from putting this program in place. And I mean, from the future, I mean, even what we've been doing, we use ultrasound for all these peripheral nerve blocks, and even in the past 6 months, we've been able to localize more specifically exactly the areas that we want, where the pain is. So, we will put this in, and instead of your whole leg being numb, now just mostly your knee is numb. You're able to extend the leg. So we're kind of making advances as we go due to the technology that we have. I mean, I think in the future we'll have different medications, some that will last longer, be more specific, be able to use less amounts. I mean, I think those are kind of our goals.
Yeah, I mean, it makes sense to, anesthetize the area that you're talking about rather than the whole body and putting things into the whole body, because obviously it has side effects for other things like your breathing and digestion and everything else that you're talking about. So that makes a lot more sense. So in terms of surgery, I mean, you've probably seen this advance quite a bit in your time here, Dr. Russinoff. The things that we were doing, less invasive type surgeries combined with this new types of pain control that can really help people to, get in and out a lot quicker, giving them reason to get these things done. So, what do you see as the future of all of this in terms of less invasive surgeries and, maybe people even just going home after these surgeries? I mean, what's the future for this?
Right, so a lot of patients, they still come to the office scared that they need a hip or a knee replacement, and they always want to know, well, when's the next thing coming out? when are you gonna be able to fix me without having to do a replacement?
Right.
And a lot of hip and knee replacement, it's similar principles the last 50 years and how we actually do the surgery. It's just the trend over the last 50 years has been to do it less invasively. We have a lot more sizing options with the implants than we used to have. And that stuff changes every year. The implants are getting better and we have more options. But it's the same surgery. But then we have different advances, like different pain methods. There's a medication we're given called tranexamic acid that cuts down on blood loss, and that's something we've also been doing over the last year. So the risk of needing a blood transfusion has gone down dramatically. I mean, it's rare that anybody needs a blood transfusion after just a routine hip or knee replacement these days. Whereas in the past, patients would donate their own blood beforehand, and usually we need to have it transfused back in after surgery. So blood management's a hot topic that we've been able to control in addition to pain. And the big trend is to figure out how to get patients home even quicker. There are some places around the country that are trying to do same-day hip and knee replacement surgery, at least in select patients who are young and healthy. But that's the push from insurance companies and so forth to get patients out quicker, and they don't want to pay for people to be in the hospital. So we have to make that leap to get them to that point. And it's a lot of trying to get more physical therapists involved and get the patients up out of bed multiple times a day, as opposed to physical therapy just seeing them once a day, which is what we used to do. So it's taken several meetings with hospital administration to get the physical therapists more involved and more active, and over the last couple of years we've made leaps and bounds in what we do for hip and knee replacements.
Yeah, I mean, I think, as you say, you point out, it's a balance. We want to get people out of here to cut costs, and also, just because people don't want to be in the hospital, but at the same token, you want to make sure that people feel safe and that they're, ready to go home, and that, they're not being, discharged prematurely, whatever, because of insurance reasons or whatever the reasons are. So trying to, strike that balance to make sure that they're medically ready and that everything is safe. So. Yeah, so I mean, I would think that this would be the type of thing that would, help people to decide about whether they want to have surgery at Hudson Valley Hospital Center. Programs like this where we can get people, in and out quicker, and they have less pain, and they feel more secure about, going home and not feeling like, once they leave here, they're going to be in a lot of pain. I think that this is a terrific thing. Is there anything else that you would like to expand upon on the anesthesiology? I'm just interested in the topic in general, because it just seems to keep, growing in terms of what we can do nowadays.
Right. I mean, like Scott was saying, in terms of where we've come. I mean, with these, in terms of pain management, we've made leaps and bounds, specifically with the use of ultrasound, with the use of bronchocatheters. We're really able to do a lot of things with local anesthesia, avoiding general anesthesia, which is going to sleep, getting breathing tube put in, having sore throat after. We're able to avoid that in a lot of the surgery that we do here. A lot of the things that we do here can be done, like I was saying, with local and with sedation, and even people that are going home the same day, they're going home faster. They're not, they're not having to spend as much time in recovery room. They're back with their families quicker. They're out the door quicker. And I mean, it's exciting. It's exciting what we're doing here. Right.
I mean, is this because we're much more advanced in terms of understanding the human body and understanding, what we can do in terms of isolating certain nerves?
I mean, I think it's a combination of not only the know-how of and having the knowledge of these techniques. I think it's also kind of the equipment and the resources that we have at this hospital. I think putting all that together is what kind of makes this program work and makes it run well.
So do you have like special educators that work with the patients, or is it just the doctor, or is it yourself, or people who teach them about this and their families? Or
I mean, everybody, we've kind of, everybody is knowledgeable on this kind of thing. Like I was saying, from when you hit the door, the nurses are speaking to patients and families, nursing and the docs are, and I think, Scott in his office is preparing people for this. I know for other surgeries, they explain kind of a little bit about the anesthesia, so they're prepared on, what to expect, and then that's kind of reinforced as they come here by nurses and doctors. So, and education is everything. If they know what to expect, maybe that, cuts down a little bit on that fear that they have going in.
Right, no, absolutely.
And we also do a preoperative joint replacement class here at the hospital.
Right. Do you talk about this in the preoperative class? Or
yeah, so they go over, it's just another way for the patients to be educated before, in the time leading up to that surgery. So it's given by one of the orthopedic nurses up on the orthopedic floor. Right. And which has also been great, having our own orthopedic floor and the same nurses, taking care of the orthopedic patients. So there's a lot of continuity of care, and everybody's on the same page from day one. And at the class, they learn about the different types of anesthesia and pain management and the nerve blocks, and the goal is to get up and get moving and get patients home, or to a rehabilitation facility. But more and more patients seem to be going home these days.
Well, that's great. I mean, I think that that certainly encourages me to know that when I do need to have that knee replacement or joint replacement, that my pain's going to be controlled, and that I'm going to get to go home a little bit quicker. So, anyway, I thank both of you for being on Health Smart. I think it's a great way to tell people at home, what goes on here at Hudson Valley Hospital Center and the new programs that we have here and the new services. So it's great, and thank you, Dr. Vent. We're glad to have
Thanks
you
for
here
having me. Thank you.
And your team, and I hope that we'll be able to expand this even further. Okay.
Thank you.
Thank you
Thanks.
very much. And thank you for joining us for another edition of Health Smart. We'll be back next month with a new topic and some new guests, but until then, be well.